Go ahead and thank you. We're going to go ahead and get started. And I know some of the people were asking the question, are we going to record this session? And the answer is yes. So welcome to the Morris and Carolyn Barkon Lectureship and Gynecological Oncology Survivorship. I'm Colleen Straub, Director of Development at Magee-Womens Foundation, and I'm stepping in tonight for Janice Devine, our Executive Director, who sends her apologies for not being able to be with us tonight. I'd like to extend our thanks to Dr. Beverly Barkon and Dr. Frank Lieberman for their continued and long-standing support. It is their dedication that allows us to continue keeping both our survivors and our healthcare professionals informed about the latest developments that impact care. The road to surviving cancer from diagnosis to recovery is a long one. The hurdles survivors face in this journey can be challenging, as you all know, which is why we are so honored to share the expertise of Dr. Stanley Roxon with you today. Dr. Roxon is internationally recognized for his pioneering work in lymphatic disease, a complication that can affect not only cancer patients, but people who experience head and neck traumas and other physical traumas. And as many as you probably already know firsthand, it can profoundly impact a patient's quality of life. Dr. Roxon will be sharing with you his insights as well as emerging issues and strategies in managing this condition. I hope you will find this information valuable and informative. We at Magee-Womens Research Institute and Foundation are able to offer these events like this thanks to our partnership with both scientists and survivors. Your participation drives what we do every day. Whether it's giving back through making a donation or participating in clinical trials, you are advancing new research discoveries that help inform care for future patients. Survivors are the best champions of women facing cancer diagnosis because you know the journey better than anyone. If you are interested in learning more about how you can partner with us to help advance this critical research, please reach out to us. Our contact information will be included in the follow-up thank you email that Denise will be sending out to all participants. And with that, I'd like to turn the discussion over to Dr. Beverly Barkon, whose courage, vision, and generosity has been the driving factor in gathering us all together today. Dr. Barkon.
Hello. Welcome to the 2021 Survivorship Workshop with the wonderful Dr. Stanley Roxon. My husband, Frank Lieberman, and I are happy to sponsor this event. Dr. Roxon was the presenter in our inaugural lecture several years ago, and we're honored to have him once again, though under quite different circumstances because of the pandemic. We've dedicated this lectureship in memory of my parents, Morris and Carolyn Barkon. Neither of them faced cancer in their lifetimes, but they instilled in me the courage to face it in mine. I am a 17-year and counting survivor of gynecological cancer. Survivorship is a part of the cancer journey, but it doesn't come without a cost. Though there are common themes, each of our cancer journeys have been different because each of us is different. When it came time to think about how to give back and pay forward, my husband and I wanted to create opportunities for both physicians and survivors to learn about the myriad issues that face survivors and their families, and to make connections with the medical teams and support resources so that positive action can be taken to ensure that this part of each woman's cancer journey results in the highest quality of life. I'm going to spend a few minutes introducing Dr. Roxon, who is very impressive. He is the Alan and Tina Neal Professor of Lymphatic Research and Medicine at Stanford University School of Medicine. After earning his medical degree from Duke University School of Medicine, he completed his internship and residency training in internal medicine at Brigham and Women's Hospital of Harvard Medical School in Boston, Massachusetts, and a fellowship in the cardiac unit of Massachusetts General Hospital. I could go on and on and on, but I think I want to give Dr. Roxon a chance to begin.
Thank you. Thank you so much for that lovely introduction and the lovely re-invitation to the University of Pittsburgh. I'm really honored to be a part of this program. So I am anxious to share slide material with everyone. So let me quickly put that on the screen. And we'll go into slideshow mode, and then we will begin the comments. And I hope that I've left sufficient time that we will be able to have some question and answer. And please feel free to ask anything that you think is related in some way to the topic of today's presentation, either to clarify anything I'm talking about or perhaps some tangential issues. Before I begin, it's typical to give disclosures because some of what I'm going to be talking about is research outcome. And it's important for you to know that I have received research grant support from these companies. And most specifically, I serve as chief medical officer of a new company called Koya, and I will be talking about a product that they are in the process of developing that I'm pretty excited about. So, but I do want you to know that I have an official relationship with them. So I'm going to start this talk with the same cartoon that I used to talk to the healthcare professionals just a little bit ago in an earlier lecture. And I think all of you in the audience are likely to be able to relate to this cartoon because to me, it's at the heart of the experience of the lymphedema patient, which is that those of you that have lymphedema or have a family member or friend or loved one touched by it, know how very important it is to day-to-day life and to all of life's experience to have crossed this threshold of having lymphedema. Unfortunately, I'm going to bet that many of the healthcare professionals that you've spoken to don't necessarily share the intensity of your feelings. And that really is something that we need to change. We need to be sure that modern medicine is prepared to embrace the importance of lymphedema and to offer as many solutions for today and tomorrow as we potentially can come by. The history of lymphedema and of lymphatic science in general is a very robust one that dates back to about 1620. It might surprise you when you realize how little many of the healthcare professionals that you've seen have a working knowledge of this system or what to do with it. To understand that this this anatomist and scientist named Gasparo Aselli actually recognized and drew anatomic diagrams of the lymphatics in a dog colon way back in 1620, just a few years after William Harvey described the blood vascular circulation. Of course, your doctors and nurses and therapists and everybody are very familiar with arteries and veins and blood flow, but not always so much with lymphatics. When you ask I'm going to say the uninitiated physician to talk about the circulation, they'll come up with a schematic that looks something like this. At the center of it, you have a very powerful pump, that's the heart. And on the left side of the heart, we have oxygenated blood that is pumped into various circuits that run in parallel from artery to capillary to vein. The veins recoalesce and bring the blood back to the heart. There's a second circulation that takes the blood to the lungs so it can be filled with oxygen. And of course, there's very important blood flow to the head and to the arms. Most of the time, when you ask for this information, folks won't remember to include this vital part of the circulation that's drawn in green, which is schematically the lymphatic system. And it's there because every time the blood goes through this circular path from heart to artery, capillary to vein, back to heart, 1% of the fluid that is contained within the circulation leaks out into the tissues. This is over 24 hours and is not able to return back to the heart unless it can be picked up by the lymphatic channels and taken back and positioned back into the blood right before the blood re-enters the heart on the venous side. In other words, without this important component of the circulation, our systems would collapse within 24 hours because there would be no more fluid volume within them. So you can see extremely vital. This is what a lymphatic vessel looks like under the light microscope. And you'll notice, as a point of reference, these dark sort of semi-lunar areas that you see a couple on this particular section, these are valves within the lymph channels that ensure that all that fluid is traveling back to the heart. And the force that delivers the fluid back to the heart is the contraction of the lymph vessels themselves. These are very mighty, powerful systems within the body to ensure that fluid flow is all in the right direction and is numerically appropriate. Now, I've just described all of the lymphatic functions that relate to the circulation, but my introduction prior to talking about lymphedema wouldn't be complete unless I also shared with you the fact that the lymphatics are part of the immune system. The immune system, as you know, is what protects your internal environment from outside invaders, whether they're bacteria or viruses, or most specifically COVID-19, also toxins and other proteins that can be harmful to your body. And the way that your immune system knows that there is a threat is because the lymph channels will carry information in the lymph to the lymph nodes so that it can be processed and the immune system can mount a response. One of the reasons that cancer survivors get lymphedema is because surgeons need to harvest and sample the lymph nodes, and the lymph nodes are being sampled because cancer wants to use the same conduit to get out of wherever it is as the lymph system uses to process all information related to the immune system. So you can see this is a very central, important function within the human body. It links the circulation of blood to the ability of the body to protect itself. Now, I'm not going to go into all the numbers on this slide, but the summary is that the lymphatics at any moment in time carry about 25, or the flow through them is about 25 milliliters per second. The surface area of the lymphatics is about 3,500 kilometers within the human body, sort of mapping end to end all the lymphatic channels that exist there. And at any moment in time, this system contains 2 liters of body fluid. There are 2 liters of lymph circulating through your body at any moment in time. And when this system doesn't work in any part of the body, then we have the capacity to develop lymphedema. Now, the context of today's lecture, of course, is in the setting of gynecologic oncology. And more generally speaking, we can acknowledge that lymphedema comes about because of cancer as the major source, certainly within the free world, within the, not the free world, but the third world. And you see the list of the kinds of cancer that we know produce lymphedema with regularity. These specific cancers are listed because these are the ones in which it is most important to either sample lymph nodes that affect the periphery of the body, and or that these lymph nodes will be exposed to radiation therapy. Now, there are other causes of lymphedema as well. The acquired type can be from trauma that is not related to cancer and not related to that kind of surgery, and also can be related to infection, which in the world at large is the leading cause of lymphedema. In underdeveloped countries, there is a parasitic infection that directly affects the lymph nodes that is the most common cause of lymphedema worldwide. There are probably 90 million individuals in the world who have lymphedema on the basis of that infection. Whatever the cause of the lymphedema, whether it's cancer or non-cancer, whether it's inborn, whether it's related to infection, it results in a lot of physical changes within the lymphatic system. And we know from lots of objective studies that all of these changes have tremendous consequences for patients. And if you are somebody who has or are dealing with lymphedema, then you can attest to this particular relationship. So how do we diagnose lymphedema? Well, most importantly, we diagnose it in the examination room, in the consultation room. A well-trained clinician should be able to discriminate lymphedema by physical examination alone, except under very unusual circumstances. However, if we need to confirm the diagnosis or there is any uncertainty, there are a variety of imaging techniques that we can use. What is considered still to be the gold standard is represented here. This is called a lymphoscintigram. And just to talk you through this briefly, these two big star-like structures are actually the patient's hands, and up here are the shoulders. So these are both arms. You can vaguely see the patient's liver here. And what we're looking at as we look at this patient, we have injected this imaging compound into the skin of both hands. And what we are imaging is the rate and pattern with which this material ascends up the arm or the leg, if we were diagnosing a leg, into the draining lymph nodes. So what you see on this patient is this is the normal side, this is the non-lymphedema side, and you can see that at the time this picture was taken, there's very dense accumulation of the material in the lymph nodes in the armpit region. On the side that has the swelling, you see that there is no uptake yet in the lymph nodes, and there's very dense staining within the path of the lymph from its site of injection to where it's going. This is lymph that was picked up in the hand, but because it's under some obstruction, it's forced back into the tissues. It's like running a car off the road. This is stained lymph that leaks back into the tissue and is therefore visible. It shouldn't be there. And the finding of this so-called dermal backflow and the delayed or absent imaging of the lymph nodes indicates that the swelling of this arm is on the basis of lymphedema. Now, we can also use MRI to see the lymph channels, and we've gotten increasingly good at this. The beauty of MRI is not only can we see the lymph channels in the limbs, where we're often interested in lymphedema, but we can actually visualize the central lymphatics, which can sometimes be a problem in lymphatic disease as well. So what you're seeing here is the thoracic duct, which is kind of like the aorta of the lymphatic system. It's the main channel that is carrying the lymph back to be deposited back into the blood circulation. And below the diaphragm, you can see the channels that lead up to the thoracic duct. The newest kid on the block, and one that is increasingly used in the context of lymphatic surgery, which we'll talk about in a moment, is called near-infrared lymphography. And basically, it uses a principle very similar to lymphoscintigraphy in that we inject the material into the skin, in the foot in this case. And again, we're visualizing the flow of lymph as this material is picked up. This is being imaged under a particular light source, and the material that's injected has autofluorescent capacity, and so we can pick up the fluorescence with the imaging device. Now, the difference between this approach and and the first one I showed you, lymphoscintigraphy, is that this one actually shows the channels themselves. The lymphoscintigram doesn't show the channels so much as it shows the pathway of lymph drainage and the patterns of lymph drainage. But the drawback of this particular approach is that because of the poor penetration of this material, we have to be pretty close to it to be able to see it. And what that means is we can only really see the lymphatics that are in and close to the skin. We can't really see the deeper structures. But if you look on this right-hand image, you're seeing that same pooling of the material in the tissues because it's under high pressure. So this is lymphedema and this is normal. Now, when we diagnose lymphedema, we typically can describe its stage. I'm going to go into some detail here, but I want to summarize for you and state quite clearly that in my practice, which is now many, many thousands of lymphedema patients, virtually every patient that I've ever treated, over 95%, are stage 2. And what that means is somebody who develops lymphedema passes very, very quickly through stage 1 into stage 2. And it is the rare patient who goes on to stage 3. And these are generally individuals who are basically untreated over long periods of time. But what you're seeing as you go down this schema, stage 0 is lymphedema that's present by some testing modality, but we really cannot see any edema yet. That's stage 0. That's a kind of a preclinical condition. Stage 1, and again, it's the earliest stage that most patients don't remain in, is when the swelling is based upon fluid that's in the tissues, but if the limb is elevated, the fluid quickly drains back to the heart. So for example, somebody in this stage of lymphedema in the leg might say, my leg swells during the day, but I go to bed at night and the next morning when I wake up, it looks okay. And then during that next day, it swells again. Eventually, we get to the point where that resolution capacity is progressively lost. And this is because the tissues in the limb with lymphedema become progressively abnormal, particularly if the lymphedema is not well treated. So let me say just a word about picking up stage 0 lymphedema. This is the stage that we would love to make the diagnosis because we feel that in a large percentage of these cases, we can arrest the problem and even potentially reverse it by aggressively treating the condition before it emerges. What we typically do at Stanford, and probably the most widely used screening modality these days, is called bioimpedance spectroscopy. And it relies on the fact that if you put an electrode on the skin and deliver a tiny amount of current, not something the person can feel, that current will travel through the tissues and you can measure the resistance that the tissue provides to the passage of that current. So the inverse of resistance is, another term for resistance is impedance. So we can measure the degree to which the tissue impedes the travel of the electricity through the tissue, which translates into the amount of time it takes to get from point A to point B. As a tissue accumulates fluid, the impedance reduces. You all know you're not supposed to talk on the telephone in the bathtub because you can electrocute yourself. Water conducts electricity well. So as the tissues increase their water content, they reduce their impedance. And we can measure that impedance. And so basically we can detect when a limb is becoming swollen even before it looks swollen or feels swollen. We can detect tiny, tiny increments of accumulation of fluid. And that allows us to make the diagnosis of stage 0 lymphedema. Eventually, though, if we don't do that job well or we don't have the ability to try, we will end up with so-called pitting edema. This is a situation where, again, there is free fluid in the tissues and it can be moved around. Here in this case, the examiner has pushed in with a finger and moved the fluid out of the way and taken a picture of this pit that is created. If the fluid can be pushed around like this and it goes away completely, so for example, with elevation of the limb, that's stage 1 lymphedema. Stage 2 lymphedema might mean that this is partially reversible, but not completely reversible. So how do we treat stage 2 lymphedema? Well, we have a variety of physical maneuvers that are designed to mobilize this extra fluid, and then through subsequent treatment, we try to prevent or limit its reaccumulation. So this is typically this kind of treatment to reduce the size of the limb in stage 1 or 2 lymphedema is performed by a lymphedema therapist, and it involves using manual stimulation to increase the contractility of the lymphatic channels, using a sophisticated bandaging technique to augment the impact of lymphatic contractility during the passage of time, and typically that's coupled with exercise. And eventually, if we do this intervention repetitively over a number of cycles, and we build the successes of one treatment session on another, on average, we can reduce the excess volume of the limb by about 50%. Some will do better, some will not do quite as well, but on average, about 50%. Wherever we get with that treatment, we eventually try, and I apologize, these are pictures of arms, even though I know that the context of today's talk is primarily leg edema, but the concept is the same. Um, we try to preserve the benefit of our treatment by the use of a chronic wearing of a compression sleeve or a stocking. Now, I want to make this point because a lot of physicians and other healthcare providers don't understand this, and I hope you as patients do understand it. The job of a sleeve or stocking is not to make the limb smaller, it is to prevent it from getting larger. So we do not treat a new lymphedema just by slapping a stocking on it. We first have to intervene to try to minimize the size of that limb and then to preserve that by using various forms of compression. We also have wraparound compression style garments. There are a variety of contexts in which these are more desirable. They accomplish pretty much the same endpoint as a conventional compression stocking. Some patients, in my utilization, the minority of patients, but some patients require compression at night because their limbs don't remain decompressed just by lying in the bed and reversing the effect of gravity. We also, at times, adjunctively utilize what are called pneumatic compression devices. So these are sometimes referred to in jargon as pumps. Many of them are not specifically pumps, but they are designed, again, to simulate much of what a lymphedema therapist would do in a treatment session by stimulating the contractility of the lymphatics and mobilizing fluid. And when a patient has one of these devices, they're typically given to them through the purchase by an insurer, and they're meant for daily use for maintenance of the lymphedema in the home setting. These are not a substitute for garments. These are not a substitute for the active treatment with a lymphedema therapist, but they are a way to maintain and optimize the treatment benefit. Now I'm going to talk to you about a new device that I have been involved with at the moment. It's being developed for arm lymphedema, but we are also in the process of trying to adapt what we've learned to leg devices, which I think will be reportable in the very near future. So the unmet clinical need in this pneumatic compression realm is that patients, many are issued these devices, but adherence to their use is variable because they require the individual to be stationary within the home for an extended period of time while they're hooked up to a machine. They're often not easy to use, to get into or out of. They're not easy to initiate self-treatment. They limit the patient's mobility, and they don't often allow the individual to be monitored from the healthcare provider setting to determine if the treatment is appropriate. So the device that we have developed is basically a wearable and mobility enhancing pneumatic compression device. It applies sequential gradient compression just like the ones that are in current use in the marketplace, but it's completely portable. It can be used on either limb. It's custom fitted. It has a 14-chamber system, and we try to use it at low pressures to try to minimize the barotrauma to the limb while adequately stimulating the lymphatic function. So this is what it looks like when it's in place. It can be put on very simply. It's designed in such a way that it is minimally difficult for an individual to do it with one hand. Inside, there is a shape memory technology that accomplishes in some ways the same thing as the conventional devices do by pumping air into chambers, but it is a little more adaptable to the unique configuration of the individual's arm. And we've been able to show through that near-infrared imaging of the type I discussed a moment ago that during the use of this device, we adequately and appropriately propel lymph through the vessels. So we did a study on all of this to try to determine if this device really has some utility, and we decided to look at a validated quality of life score. That was our main interest, to determine whether this actually improved quality of life or maintained quality of life in treated patients. And we also looked at the ability of the device to maintain limb volume once this was utilized, because these were patients who had already been aggressively treated by a lymphedema therapist. As you can see, ultimately, we think that the potential indication for use of these devices is going to be pretty broad, including all forms of lymphedema, as well as other causes of edema as well. So what we found is that the quality of life not only was maintained, but actually improved by a statistically significant degree in the individuals who utilized this new device. And we also found that not only were we able to maintain benefit, but in terms of the reduction in volume or maintenance of volume, but it actually, the volumes of the patient's limbs that were treated improved in a statistically significant way during the period of time that they used the device. The device is designed to be able to interface through smart technology with smartphones, which allows us to monitor adherence and compliance, as well as potentially in the long run to make adjustments in the settings in order to adapt to what is happening to the patient. And during our study, we found that the compliance with the device was extremely high, much higher than what is conventionally observed with the marketed devices now. So in general, we're pretty excited about the impact of this and the potential impact of this. And for those of you that are being treated for leg edema, stay tuned, because I think I will hope within the near future, within the next year, be able to report similar outcomes data for newly developed leg device. The arm device is starting to be marketed now in selected markets within the United States, with the hope eventually to have wide distribution. So the theory in general behind everything we talked about is that we want to make the diagnosis as early as we'd like. I'm sorry, this slide is reformatted itself, so some of the background is not there, but you get the general idea that the earlier we can intervene, the more we feel we can limit the physical consequences of lymphedema. But even when we intervene late, we want to arrest further development and reduce the impact of whatever is currently present. So all of that surrounds this notion of pitting edema, because that's the component that responds to manual lymphatic massage, to compression bandaging, to pneumatic compression devices, or the new kind of device that I showed you. But unfortunately, with the passage of time, many patients get to the later stages of the later manifestations of stage 2, and the edema eventually becomes predominantly non-pitting. And basically, what happens in this circumstance, and this is partly my interpretation, we do know that there is tissue overgrowth that supervenes in these limbs. And what happens is, whatever the volume of fluid that was there to distend the limb initially, over time gets replaced fundamentally with an equivalent volume of tissue overgrowth. So the limb stays as large as it always was, but now becomes decreasingly responsive to things like pneumatic compression, to manual therapies, to everything that we know mobilizes fluid, because it's no longer fluid, it's now tissue mass. And this is the part of lymphedema that has been the heartbreaking part, because historically we haven't had anything that we can do really to counteract this part of it. If I show you what an MRI of a thigh looks like with lymphedema, you will get the idea. So this is the femur bone. These are the soft tissues of the thigh, including the muscle. And here you see the skin. Now the skin here is many, many, many millimeters thick. Ordinarily, we can barely see the skin on an MRI, but you can see what has happened to the skin. It looks like the cut edge of a grapefruit. It has really increased in volume and cellular mass, and similar things are happening beneath the skin as well. This is a post-mortem section. I apologize if anybody's upset by this. This is a post-mortem section of a limb of long-standing lymphedema, to once again show you not only the skin thickening, but what I want to point out is this huge layer of fatty overgrowth that has occurred in this arm that is the basic reason that this arm was no longer normal in size. Now, we all have a fatty layer under the skin throughout our bodies. It's an insulation layer that keeps us from getting too cold in the wintertime. But what happens in lymphedema is that this fatty layer grows to very disproportionate sizes, and this becomes the main reason that the limb is enlarged. So what do we do about all of this? Well, I first of all want to talk about well, let me just, before I get to that, let me just show you what the skin looks like under the microscope when it's untreated in lymphedema, sorry. And then this is what a normal skin looks like. Look at all the thickening that you can see under the microscope. Now, this is taken from a mouse, and the skin in this mouse goes from this blue point here to the outside edge. You can see how big it is. This is a similar section in a mouse with lymphedema, and this blue section here would be way down here. This is all skin. This is the amount of overgrowth that we see in lymphedema. We also see dilation of lymphatic channels because the lymph outflow is obstructed. There are lots of structural consequences of longstanding lymphedema. So let's talk about what we can do about that fatty overgrowth, and then I'm going to get into some more research aspect of things. There is a surgery that has been evolved since the late 1990s to basically take all that extra material that I showed you in that arm section, all that fatty overgrowth, and remove it with a very specialized liposuction approach. You've all probably heard of liposuction or know about it. This is a specific type of liposuction for lymphedema. It's done under general anesthesia, and we go in and we take out all of that fatty overgrowth. And basically, when we do that, and then use compression in a very aggressive way, we can take a chronically swollen arm like this one and restore it to normal size. Now, this woman is 12 years out from the surgery that reduced the arm from this to this, and she's been able to maintain it completely through the appropriate use of compression. So that is what we currently do to deal with that fatty overgrowth. Now, you can think of that fat as kind of scar tissue. So doing that kind of surgery does not in any way heal the lymphatic damage. It only takes away the scar that has occurred because of the damage. I do want to say a word about some of the surgeries that we do to try to reverse the lymphatic damage, and these are increasingly done in centers around the United States. One type of surgery is called lymphovenous anastomosis, or some people call it bypass. And basically, what you're looking at here, it's a schematic. The green is a lymph channel, and the blue is a vein. And if the surgeon can identify a lymph channel, let's say within a swollen leg that sits next to a vein, the surgeon can surgically attach the lymph channel to the vein and drain the lymph directly into the venous system. Now, remember that in normal biology, in normal anatomy, the lymph does eventually drain into the venous system. It just does it way up in the chest. What we're doing here is allowing that to occur at the level of the limb that's swollen. Another technique that is employed, sometimes lymphovenous anastomosis can't be performed or isn't the right surgery, or sometimes we do this as combined procedures. Sometimes we do what's called a vascularized lymph node transfer. And what we do here is to create a skin graft in which we harvest normal lymph tissue in a skin graft and graft that skin into the lymphedema limb. And the purpose of the graft is for that new lymph tissue to stimulate lymphatic repair and to make the existing lymph channels more effective at doing the job that they're not doing. Now, part of the problem with that second surgery is we do it and sometimes it doesn't work at all, or sometimes it works to a minimal degree. We can never really predict why it will or won't be successful, but we do know from animal studies that one of the determinants for whether it's going to be successful is how well the transplanted lymph tissue engrafts itself into the existing lymphatic circulation around it. So it's just like doing a tree graft. You know, you have to have, you can put the grafted portion onto the base of the tree, but those two things need to knit together. And the degree to which that doesn't or does happen will determine the degree to which the lymphedema improves or does not improve. So that's basically the message in this animal study, which I won't go into in more detail. But I do want to talk about this development, which I've been involved in, which is that we have developed what we are calling a biological scaffold that makes it increasingly possible for the transplanted lymph tissue to have a successful graft. So this material that is being held by the surgeon is this scaffold. You can see what it looks like under the naked eye, and this piece is about 6 inches long. But if you look at it under cross-section under a microscope, you can see that this material is made of normal mammalian collagen. We cleave off the telopeptide that makes it antigenic, so there's no immune response to this. This is bovine collagen, so it comes from cows. And in a post-processing approach, we take those collagen fibrils, which untreated would look like a ball of yarn that a cat played with, and we align all of the fibers in one direction. And that creates a structure that looks like this under the microscope, which is a perfect surface for lymph lining cells to grow and to grow across rapidly. That's what it looks like under higher power. So the purpose of all of this is to provide a surface area that will allow the bridging cells to grow and to create a union between what we're putting in surgically and what's already there within the patient. And we've been able to show in the laboratory that in fact these scaffolds are wonderful surfaces on which these lymphatic endothelial cells grow. And when we look at a model of leg lymphedema that we can create in the pig, and we do that by removing lymph nodes and doing radiation therapy, just like happens in the human cancer situation. This is where the radiation occurred. That pig will develop lymphedema, but if we go back in and place these scaffolds in the surgical site, we can show that not only does the lymphedema resolve, but we can show under the microscope that new lymph channels have grown directly next to these collagen fibers that remain of the scaffold. These eventually all go away because this is normal mammalian collagen that gets digested by the animal or the human in this case over time. But what is left behind are new stable lymphatic channels that allow theoretically a transplanted lymph node to connect to the existing lymphatic channels. Now, even more exciting, in my opinion, for the future is the fact that we've been able to show that using a similar technique, if we place these scaffolds in the surgical site at the time that we remove lymph nodes for cancer treatment, for example, we can actually prevent lymphedema. Because what happens is that the scaffolds encourage the lymph channels to develop collaterals to take lymph out of the area. And what we observed in a mouse model is that while untreated, all of these mice will develop lymphedema. If we place the scaffolds at the time of surgery, even if we're going to irradiate the animals later, they are prevented from developing lymphedema. Here's a higher power view of those collateral lymph channels that have developed because of the scaffold. Now, I'm going to finish up by talking about the horizon of drug therapy, which has been the main thrust of my research. I do want to say that lymphedema is a really complex beast, and it has many different manifestations, and where you focus your attention will determine where you think you can have an impact in diagnosis or treatment. It's a little bit like the proverbial illustration of the blind men examining the elephant depends on what part of the elephant you put your hands on. In this case, my blind man approach to lymphedema has been to look at the role of inflammation. And basically, we started this work way back in 2006 by using a mouse model of lymphedema and sampling skin either from mice that had lymphedema or mice that had surgery in which the lymphatics were not damaged, and comparing the two patterns of gene expression. And what we found is that in lymphedema, almost all of the changes that occur that take the animal from normal to lymphedema have to do unexpectedly with inflammation and with the immune response. Now, in one sense, maybe it shouldn't be unexpected. I started this talk by telling you how important the lymphatics are to the immune system. But at that point in time, people were not thinking about lymphedema as an inflammatory disease. They were thinking about it as a sewer problem. And it is anything but that. We've subsequently repeated similar work in human studies in which we've been able to show exactly the same pattern, where most of the changes in human skin lymphedema compared to normal skin lymphedema have to do with inflammation and the immune system. There are other changes, of course, as well, because as we've seen, lymphedema is complex, but everything seems to be predominated by inflammation. And so we have focused our interest in lymphedema on this inflammation piece to try to see if we could have an impact on the disease magnitude and expression. And to make a really long story pretty short, we ended up utilizing an anti-inflammatory drug that impairs two different pathways of inflammation. And basically what we found is that our drug, which successfully reverses lymphedema both in mice and has a successful impact in human lymphedema, is totally dependent on this pathway that has not previously been appreciated to play a role, called the leukotrienes. So the leukotrienes, and specifically this molecule, LTB4, seems to be a central driver in the worsening manifestations of lymphedema. This work is still ongoing. We've completed 2 clinical trials, one of which is published. I do think that the future is bright for drug therapy because I think we've discovered some very important roles for these inflammatory pathways and the ways in which they prevent the lymphatics from healing themselves appropriately. But I want to finish my comments by saying, sort of summing up everything I've talked about, which is to say that lymphedema is very common. It is very important to everybody who has it. It shouldn't be ignored. It is a problem that tends to progress and become more complex as time goes on. And we know that many of the outcomes that we have currently and many more that we will have in the future can have an enormous impact on this disease and its impact on individuals who are affected. And I'd like to conclude my comments by saying, in a very optimistic way, I do think anything is possible. When I look back on when I started working in the lymphatic system 30 years ago, I would have been absolutely incredulous and astounded to believe that we are where we are today. I know it's not where we want to be ultimately, but we're on a path, and the path appears to be very successful. So for those of you that are dealing with lymphedema, please be optimistic. I think there is always and inevitably hope on the horizon. So with that, I want to thank you for your attention. I'm going to stop sharing the slides and let me see if we have some questions. Let's see.
I do want to just mention about the questions. So Dr. Roxon is going to look at the questions. For those of you that have asked very specific questions, we're going to email him your questions so that he can respond back to you directly. We don't want to get into any personal information or recommendations of that sort of thing. So I think in looking at the questions, Dr. Roxon, perhaps Beverly's question, that her question was earlier in your presentation. She asked for lower extremity lymphedema.
Yeah.
Will your device affect mobility? I think that's probably a question that you could answer now for the group.
Absolutely. And I'm happy to answer specific questions generically. I will tell you, no matter whether you email me or ask them here, I won't give any personal advice or personal interpretations because I can't. That's medical legally not appropriate. As far as the new device, the whole intent is for it to ultimately be a hybrid between a stocking and a pneumatic compression device. So the intent is you wear it, you walk around with it. Initially, the design is, of course, to use it for limited periods of time as we do the conventional pneumatic devices. But ultimately, I think it's entirely feasible that one might use this over extended periods of the day. It is going to be feasible to walk around, to sit, to stand, to do everything you need to do, and to not be limited by being attached to anything. So that's exciting to me. I think it's a big advance, and also allows us potentially to take optimal mechanical control of the edema. So it's looking that way very much for the arms. And I can tell you for the 30 or 40 women who participated in our first trial, they're all clamoring to get a permanent version of it because they're all enthralled with it. So I would imagine a very similar response. And the leg is still in prototype, but we're gearing up toward starting studies with it. So, I think that's really very exciting. The next question is about repeated infection in lymphedema. I should say that conventional wisdom states that more than 50% of lymphedema patients get at least one episode of cellulitis in their lifetime, and over 30% have repeated infection. So it is a common attribute of lymphedema, and there really are a couple of reasons for it. Number one is that the barrier that the skin creates toward bacterial invasion is altered. The skin is not normal, it's not healthy. And consequently, the barrier function is eroded to a degree, coupled with the fact that the lymph system, which is meant to alert the central immune mechanisms that an infection is happening, are blunted. So when you take those two things together, you set the stage for infection. Now, the infections are typically normal bacteria that live on the skin, that live on all of our skin. So the problem is not coming in contact with some weird organism. The problem is that the body cannot defend itself in the normal way. So the question was, does repeated infection affect the skin? And unfortunately, yes, I think it does. With each round of infection, there is potentially further lymphatic damage. And that in turn sets the stage for the skin potentially to progress. So it is our belief and it is our hope that aggressive physical measures to treat the lymphedema will minimize the likelihood of infection. And some of the work that I've been involved with related to the more traditional pneumatic compression devices suggest that some of the better advanced compression devices do in fact significantly limit hospitalizations, emergency room visits, and medical costs in general. And by implication, this is because of the reduction in the amount of infection that's observed. Okay. Let's see if there's maybe one more question I can answer.
There's one about exercise and not being overweight, or there's also a question about the PD test. So one of those two you might be able to answer now.
Probably will answer. I don't know much about the PD test, so probably I'm gonna pass on that one. But the Energizer Bunny wants to know, does exercise and not being overweight help the post-surgical lymphedema? The answer is a resounding yes. So let me say that when we look at the risk factors that help to discriminate the people who will and won't develop lymphedema in any given cancer setting, obesity is one that shows up almost routinely. So certainly starting out with less than an ideal body weight is going to increase the risk of lymphedema. The other issue to point out is that exercise augments lymphatic function. When your muscles are active, if you're going out for a walk or riding your bicycle or using your rowing machine or whatever it is you do for exercise, every contraction of the muscles in the legs will have an effect on lymph flow that is similar to what those pneumatic compression devices do. So when your lymph channels are still working properly and you're exercising, you're really optimizing their function. Once you develop lymphedema, you get the same benefit if you wear your compression when you exercise. Because in the absence of the garment, the positive impact of exercise will be overwhelmed by the fact that exercise increases blood flow. And I've already told you that for every liter of blood that goes through your leg, 1% of that is going to end up in the tissues and need to be handled by the lymph channels. If the lymph channels aren't working well and you increase blood flow, you're going to increase edema. But if you're wearing a garment to prevent that extra fluid accumulation, then you get all the benefit of exercise on lymph flow without increasing edema. So I think with that, we'll probably end it for here.
Great. Thank you so much, Dr. Roxon. I just want to take a couple of minutes here to thank everyone for attending today's Morris and Carolyn Barkon lectureship in Gynecological Oncology Survivorship. We'd also like to thank Dr. Roxon for sharing some really great information. And it goes without saying, we appreciate the support from Dr. Barkon and Dr. Lieberman that we may bring you this information. For those of you that are interested, we have, I want to send out a reminder, a save the date. Our 32nd annual Magee Survivor Celebration will be held virtually on June 13th, and information on how to register for that event will be shared in an upcoming email. And also a reminder that should you wish to discuss how you can help support Magee-Womens Research Institute and Foundation, either through clinical trials, through supporting research itself, any questions that you may have, again, in the follow-up email will be Janice Devine, who is our executive director of the foundation. Her contact information will be in there, and then you can ask questions of her. So again, I just want to thank everyone for taking a little bit of time during their evening and attending this presentation. I hope that you found it really worthwhile. I did. It's fascinating to see the work that is being done and the progress that we've made, but there's still a lot more work to be done, and we appreciate all that Dr. Roxon is doing. And we certainly appreciate Drs. Beverly Barkon and Dr. Frank Lieberman for giving us the financial support to be able to put this kind of a workshop on. So thank you all very much.
Thank you.
Bye-bye.